Care Week lecture. My name's Ian Campbell, National Communications Director with Palliative Care Australia. Thank you so much for being here. Now, you're all special in my eyes, but can I acknowledge the presence of Jed Carney, Assistant Minister for Health and Aged Care, who has become the Minister for Palliative Care in our eyes. Also with us are the co-conveners of our Parliamentary Friends for Palliative Care group, Senator Katrina Billick and the Honourable Nola Marino MP and members of the group. Another of our special guests here today, Chair of Palliative Care Australia, Professor Mira Agar, and members of the PCA board, and CEO of Palliative Care Australia, Camilla Rowland. A special mention to Sarah de Jong, the founder of our partner organisation today, 1,000 Hearts, and I'll tell you more about their great work shortly. And of course, welcome to Professor David Currow, Vice-Chancellor of the University of Wollongong, who will share his work and wisdom with us shortly. A special welcome to my mum, Laurie Slater, who was a palliative care clinical nurse consultant before she retired. Thanks for being here, Mum. We gather on the lands of the Ngunnawal and Ngambri people, and I pay my respects to elders past and present. One such person is Paul Girawar House, who is here to welcome us to country.
Mandangu, Warragawari, thank you, Ian, and Yuridu Marang, Buramaramang. Good day, everyone. Marambang Malang, Noya Goya Malang. It's wonderful, it's fabulous to be here. Nina Nain Mura Buramba Bira, Gawayambana, Nina Nurambango, to share this welcome to country with you all. Yilingalangbu, Gibabangu, Wugabu, Migabu, Diran Nilbang Mayin. Ladies and gentlemen, young men, young women, distinguished guests, parliamentarians, Nyarin Jamali, Nyambri, Cambri, Wogalu, Wallabalawa, Nunawa, Nagariga, Waradri, Mujigang, Yanangbu Jayandu. My respects to Nyambri, Cambri, Wogalu, Wallabalawa, Nunawa, Nagariga, Waradri, elders past and present. Nyarin Jamarabu, Mujigango, Nurambanjigo, Nenya Yiridu. My respects to all people from all parts of the country. Nyambri, Cambri, Wogalu, Wallabalawa, Mayin Gaimbanya Ninoga, Nurambango Dara, Nyambri, Cambri, Wogalu, Wallabalawa. Ngunnawal people, welcome you all to country. Wurai Nyang, Wurai Mayin, no language, no people. Wallawin Mayin, Wallawin Nurambango. Healthy people, healthy country. Nadu Wuragabigi, Balabambo Gubu, Balagi Bangubu, Guingulila, Dumbali now Murawai Marambu. We listen to the old people, the ancestors, the elders, and they show us the good path, the right path, the straight path. Maramara Muro, creating pathways. Murawaro on track. Dulagang Muro, straight path. Guingulila, Bilingali now, Yamamali now, Walamali now. Our old people, they nurture us, they guide us, they protect us. Mambawara Naminyagu, Wuragabinya Wuradarego, Winningalago Balago, looking to see, listening to hear, and learning to understand. Niani Yinjamali Nurabangila Balanin, Wallawin Galanga, Bangber Yaningingo, Niani Mawang Yao Biligigila, Yaman Bill Giri, Yani Marambo Bagrigan, Yaningingo. We look after country for our children and we teach and we learn what is right for all on country. Murun Muginya Yinjamara, Muramuru, Wirambira Nurambango. Living a respectful way of life cares for country. Yinjamara, Wirambira, Marando Gobu, Gihira Gobu, Yanda Gobu. Respect is taking responsibility for the now, the past, the present, and the future. Our welcome to country is always made in the spirit of peace, in a desire for harmony and reconciliation for all people of modern Australia. And our main aim always is to establish an atmosphere of mutual respect through the acknowledgement of our ancestors and the recognition of our rights to declare a special place in the pre and post history of the Canberra region. The name Canberra is derived from the name of our people and country here, the Ngambri, Cambri, Canberra. Yinjamara, Yinjamaro Gidjul, Yinjamarabo, Yinjamali. Powerful words on country. These words are way of life. They're ideology, and they mean many good things. They're good nutrients. To go slow, be patient, be polite, be gentle, take responsibility, uphold. And that gift, and we thank the 6.2 million people who supported our gift last year of 60,000 gift of love, respect, safety and belonging the nurturing, the sheltering, the sacrifice, the security, the morals, the values from our people of this country to everyone in this country. And we thank the people who supported our fight to be recognised in our own country. We still haven't seen that yet, and that right of recognition and respect is the law of the land. The law of the land talks about giving respect and honour to all people from all parts of the country, and then people will respect you. Respect everything living and growing. Respect, number one, respect is everything. Respect is in the grinding stones and the carved trees made long ago on country. Respect is in our creator and our protector, Bayami, our key totems, the crow and the eagle. Maragaladal walan mayangalang. We hold fast to each other, empower the people. Walan gunmala maramara gure. We brave, make change. Diriyamana murawara nawanbira. We get up, we stand up, and we show up. Maramara niya giramar maranya. Respect shapes us and lifts up the people. In the end, when the dust is settled on all of us, on our lives, all we get to take with us is our dignity and our integrity and the love and respect we have for ourselves and our families. Respect creates people who care for each other. So welcome to country. I'm going to play a song. I'd like to thank Ian and all the team, Palliative Care, for your kind support over the years to be able to speak here on country. Dr. Matilda Williams' house. I'd like to acknowledge my mother, Dr. Matilda Williams' house, my matriarch, and I acknowledge all the matriarchs here in the room. Because of her, I can. My mother is the current 2023 24 Senior National NAIDOC Senior Female Elder of the Year. My mother provided the first ever welcome to country here at the opening of the 42nd of Parliament in 2008 and went on for the 43rd and 44th. And we were gifted that 2 years ago. And we don't take these protocols here in this place for granted. We as Aboriginal people come from country, we stay on country, and we're here though to share the love and respect with all the people. So with that, I'm going to play a song on the Yiriki to share with you all. So it's wonderful. Noi Goi Malang, Marambang Malang to be here. Mandangul. Thank you very much.
Get up, show up, stand up. Great words, Paul. Thanks for the motivation. Thank you. Thank you for being here again and sharing your wisdom and your culture with us. To add their own welcome to today's event are our parliamentary friends, co-conveners. Nola Marino has been the member for Forest in WA since 2007, and Senator Katrina Billick has represented Tasmania also since 2007. Both have skin in the game and their own personal connections with palliative care. Please welcome Nola and Katrina.
You are. You're always polite, no, most of the time. Thank you, Paul, for that amazing welcome to country. It was really lovely, and I particularly like the words healthy people, healthy country. I think that resonates really well today. I also would like to begin by acknowledging the traditional owners of the land on which we meet, the Ngunnawal and the Ngambri people, and pay respects to their elders past and present. And I'm absolutely delighted to be here again at another palliative care event. Nola and I, for those of you that don't know us, have been doing this, Nola and Katrina and Nola sideshow, tag team for a number of years. And I think that what it shows is that there is a lot of areas where it doesn't matter what political party you come from, you can share the same views. And it's really important in the area of palliative care, I think, that right across government and the opposition and even the independents, that people understand that. So, as I said, Nola and I have been doing this for years. We've got so good at it, I even forgot to talk to her about what we were going to do today. So, anyway, I'm really looking forward to Professor Currow's lecture about the future of the care economy. And I noticed in the promotional material for Professor Currow's lecture that there is reference to the rapidly changing demographics of living, dying and caring. And so while I don't know exactly what he's going to talk about, I've got some sense that this may be around the ageing of our population and the impact this is going to have on care needs. Yes, definitely. I'd rather be ageing than not, just to be clear.
I'm happy to be here.
Yeah, that's right. The consequence of an ageing population is not just an increase in the number of people with life-limiting illness, but also an increase in the complexity of those illnesses. And we've seen, for example, that by 2058, the number of people in Australia with dementia is projected to more than double. We can also expect to see an increase in the proportion of people with chronic conditions, such as hypertension and diabetes. And as such, we can expect the demand for those involved in palliative care, be it workers, volunteers, carers, and even researchers, to grow dramatically. And when I say dramatically, I mean not just in line with population growth, but even faster than that. And this is happening while in many cases we are still struggling to meet the challenges of delivering quality palliative care now. In close to 10 years since the release of the Grattan Institute's Dying Well report, many of the issues raised in that report still remain unresolved. Australia has a huge challenge on its hands, and I'm glad we've got strong advocates like Palliative Care Australia and its affiliates to help guide the discussion as we work to meet those challenges. Your turn.
Oh, I'm not going to say a lot, except I'm so pleased that you're all here. I think that's absolutely fantastic, and thank you for coming to support Palliative Care Australia in the launch of National Palliative Care Week. Just for instance, this morning I had a gentleman visit me who has recently been diagnosed with Parkinson's disease. And one of the things we've talked about frequently with Palliative Care Australia is the need, Katrina, for very good end-of-life care planning that goes along with good palliative care. And it doesn't matter, there's some wonderful younger people here, perhaps a little younger than you and I. But can I encourage you, no matter what your age is, to consider what you're going to put in your end-of-life care plan if you can't speak tomorrow, and make decisions for yourself. My mum was a very old-fashioned first aider from Brunswick Junction who worked to get Brunswick's first and second ambulance. But she always said to us, something's going to kill you. You just don't know when, and you don't know what it is. And that's true. So good planning matters, but fabulous palliative care and what you would want in your palliative care, when it's you that perhaps can't speak and can't direct what you want, you need great people through Palliative Care Australia and what's offered in our communities to make sure that your journey in those last weeks, days or months of your lives are the best they can be, and they are what you want them to be. So thank you for your interest in being here today. As Katrina said, this is something that's very close to our hearts, and we're really pleased that it's close to yours as well.
Thank you, Nola and Katrina. Katrina, you're a great double act. When you finish your service here at Parliament, you should really take this show on the road. So thank you. Our next speaker has her hands on the wheels of reform within government. which just last week marked 2 years in office. Her presence here today highlights her commitment to the task at hand, but also her interest in what still needs to happen. Please welcome Assistant Minister for Health and Aged Care, Jed Carney.
Thanks, Ian, for that lovely introduction. And I too acknowledge and thank Paul. He's already left, but I thank Paul for his beautiful welcome to country, a proud Ngambri man. And I pay my respects to elders past and present and extend that respect to First Nations people joining us today. Thank you, Camilla, for asking me along today. I always welcome an invitation from Palliative Care Australia. I also thank all the members of Friends of Palliative Care. Katrina and Nola, you are amazing. You are tireless. You are loud advocates. You're fabulous voices for the causes that you champion, and you really do champion them. So I thank you for that, and it does make a huge difference. Professor Mira Agar, PCA Board Chair, and Sarah De Jong. I didn't quite finish my little heart down the back there, but I hope you can finish it off for me, and congratulations on the 1000 Hearts Foundation. I have had the honour of addressing the palliative care community a number of times now. You've heard me speak of my own experience with palliative care teams, and the palliative care community more broadly. Both my mum at 72 and my beautiful nephew at 17, he died of an aggressive Ewing sarcoma. My mum died of a rare autoimmune disease. And both times the whole family were supported, and we were very grateful for that support from wonderful palliative care services. For those of you who've heard me talk about my mum's experience, you may recall that my brother, who was her carer through that time, used to call the palliative care nurses Pal Care ninjas, because they seemed to just slide in and out and perform amazing tasks with great sensitivity, very quietly and magically to a degree. And they really were the glue that kept us all together. But I've also spoken about how my nephew at 17 years of age, tragically died at 17, had a vastly different idea of palliative care to my mother. Very different. He didn't want the whole family sitting around saying the rosary around her bed, I can tell you. And so that's why I was really honoured to launch the Paediatric Palliative Care Guide, if you recall. An amazing document which I really understood, having had my own personal experience of how a young person's journey is quite different to an older person's. And Nola, you're absolutely right, Katrina. It needs to be it's a very personal thing, and it needs to be tailored very specifically for each person. I know how dedicated people who work in palliative care are. I know how special you are to work in this area, and how important you are to the broader healthcare team and to the system. I do know it's rewarding. People who work in the system tell me, Camilla was just saying she kept coming back to it in her whole career, because it is really a very rewarding place to be. I was a nurse in a very large hospital. I worked on an acute bowel ward where we did surgery, but a bit of medical stuff as well for the GIT. I always say, everything from the throat to the anus, I was your gal. That's who we looked after. But very often people would come in, they'd be operated on, and unfortunately they would come back to the ward and we'd be told, we can't do anything for this patient. They're going to die. And they would die very quickly on the ward with us. And I often think back at that time, and I wish that I had had special training to help the family and the patients through that. I was a good nurse, I think, and my colleagues were, and we did our very, very best in those trying circumstances, but it really brought home to me now when I reflect back, just how much better it would have been if we'd really had it. I'm old now, this is a long time ago, but if we'd really had that very good palliative care training as acute care nurses. Because it is a specialist area. It requires very specialist skills. And thank goodness we have you all. Thank goodness. So thank you for your work, for your advocacy, and for bringing palliative care here, right here to Parliament House, where the policymakers are, where you have wonderful people like our co-conveners who can elevate your voice, but where we can see you, where we can hear you, and where we can learn from you about what needs to be done. Can I please acknowledge Professor David Currow, who will deliver the very first National Palliative Care Week lecture. What a great initiative. I really look forward to this. This is amazing. And it is terrific to have your address about the future of the care economy. I was just chatting to you before about how important this is. It really warms my heart as a nurse. I think the care economy has been neglected for a long time, and I must admit that as a nurse and a woman who, let's face it, make up the vast majority of the care economy workforce, who rely intently on the care economy, I started educating the Labor caucus about the care economy from day one. I had some great allies in the caucus, Katrina being one of them, and because not everybody understood what it was. They didn't know who it was. They didn't even know what it did. I remember occasionally the treasurer would look at me with this raised eyebrow. What is this economy that you speak of, Jed Carney? But it is the care economy. So imagine my pleasure when at the last election, the Labor Party ran pretty much its entire election campaign on the care economy. We ran it on aged care. We ran it on Medicare reform, and we ran it on childcare reform. And I'm so pleased that we have delivered a huge amount in those areas. This was a massive shift, and now everybody knows what the care economy is. And so I thank all of your hard work for that. Back to palliative care, and I know there's a lot more, and I'm sure we're going to hear about the gaps in the care economy and what needs to happen, and I'm really looking forward to that. But Australia's happy-go-lucky and optimistic national character means that we often have a reluctance to accept or even acknowledge death as part of life. At times, it's just too hard. And some of you may remember that last year I opened the upgraded hospice, Very Special Kids, in my hometown of Melbourne. And before I attended that event, I did feel a very deep sadness thinking about the kids and the families there. I still think about that day so often. It is really heartwarming and heartbreaking at the same time to see the services that they provide, but it really instilled in me the importance of palliative care. And we need to talk about it more. We need to have more of these events, and I'm so looking forward to the yearly Palliative Care Week lecture. I think it will be wonderful. So please know that the Albanese Labor government wants to ensure every person with a life-limiting illness of whatever age has access to quality, holistic palliative care, provided where they want it, in their location of choice, whether that's in a hospital, in a hospice, aged care facility, or indeed in their home. And this is a vision that everyone in this room knows well, and I thank you so much for your advocacy in this space. We do know there's work to do. We are determined to continue our reform agenda in the health system. We have started that, and we want to future-proof it for long-term and ensure that all parts of our health and aged care and our disability systems work together to provide the best care for each individual person. As I said, there are many reforms already in hand, and there are some really great programs already out there. But through, for example, the Support at Home program reforms, we're improving access to quality palliative care at home. We're carefully considering the recommendations of 2 recent major inquiries into the interface of disability and palliative care, which highlight the need for better integration and coordination across those sectors. And this month, or this year, the budget specifically targeted palliative care, with funding palliative care programs targeting residential aged care and more support for people with dementia. I had to give the government a bit of a plug. It's my job. So I just tell you that that's the end of that bit. So, you know, I'm really pleased with what's happening in palliative care. I'm pleased that you're leading the change there. I'm really interested in lots of projects that you're involved with, like the Caring at Home report on the National Core Community Palliative Care Medicines List, for example, which identifies core medicines that can be prescribed for patients who have palliative care at home at the end of life. That is a wonderful initiative, I think. Anyway, there's a range of programs. I've got lists of them here, but I won't go into them. You all probably know them very, very well. I think I just want to say thank you. Thank you so much for coming, for being here. Thank you for the time you put into such an important thing. Thank you for making an incredible difference to people's lives. Thank you.
Thank you, Minister. Your passion for what we do is palpable. You can see why we call her the Minister for Palliative Care these days. And thank you for staring down those raised eyebrows from the Treasurer. Let us know how we can help you with that in the future. A very special part of today's event is our partnership with 1,000 Hearts and the opportunity it presents you. Led by Sarah de Jong, 1,000 Hearts is a global kindness community based in Tasmania who've become such a part of our palliative care community. Through the simple act of sewing and then sharing colourful felt pocket hearts, 1,000 Hearts and its community of sewers seek to spread kindness, respect and acknowledgement, to create a groundswell that leads to a more compassionate world. Sarah and her locally based community of sewers are here with us today to extend their mission and introduce you to the new symbol of the palliative care sector, the orange heart. You're invited to join them today and make your own orange pocket heart, sewing love and support into each stitch. Then you can either share your pocket heart with someone who needs it, or you can keep it for yourself as a reminder of the power of kindness, both to yourself and the world around you. For the palliative care sector, the orange heart represents the life still to be lived while engaging in palliative care, and the connection that health professionals and volunteers share with patients and families, and the close bonds that form during their unique palliative care journey. If you have time, please join our sew-up crew down the back, or you're welcome to take one of the pre-made packs away with you today as a show of support. Thank you to Sarah and her community of heartists who are here today. Thank you. This is our first National Palliative Care Week lecture. It's a tradition we're wanting to grow each year in and around National Palliative Care Week, where we invite a distinguished member of the palliative care community to challenge our thinking and our work. And we're off to a strong start in 2024. The demographics of living, dying and caring are evolving rapidly. With that comes a clear and pressing challenge to the care economy. Professor David Currow believes government, health services and the community all have a role to play in meeting our future care needs. Professor Currow is a physician by training. He's a widely published academic and researcher. He's previously been the New South Wales Chief Cancer Officer, Chief Executive Officer of the Cancer Institute of New South Wales, and was the Foundation Chief Executive Officer of Cancer Australia. He's currently the Deputy Vice-Chancellor of Research and Sustainable Futures at the University of Wollongong in New South Wales. At the conclusion of his address today, Camilla Rowland, CEO of Palliative Care Australia, will facilitate Q&A with you here in the audience, so have your questions ready to go. But first, to deliver the inaugural National Palliative Care Week lecture, please welcome Professor David Currow.
Good afternoon, colleagues, ladies and gentlemen, the conveners of the Parliamentary Friends of Palliative Care. Thank you for the opportunity to speak here today, to Camilla and to Mira, who are doing a fantastic job in leading Palliative Care Australia to the next level. As we think about the care economy, we're challenged with what the future holds. So as we think about that, can I have a quick show of hands? Who would like to die of cancer? Heart failure? End-stage respiratory disease? Who has the fantasy that they're going to go to sleep one night and simply not wake up the next morning? Yeah, I thought that might be the case. Actually, what most of you have voted for is that you want to die of dementia, because that's the reality that we face. And the challenge for us today is that the world has changed irrevocably, and we'll see that in the next few minutes. But regardless of the diagnosis, the bottom line is that end-of-life care needs are almost identical, whatever that cause. And although the emphasis has been so strongly on cancer for so many services, the reality is that people with end-stage respiratory disease, end-stage cardiac disease, end-stage hepatic or renal disease, neurodegenerative disease, the needs are very similar. And we'll come back to that in a few moments. I want to reflect on palliative care for just a few slides to think about a few issues. In reality, in the clinic, the people that I see who are really angry, not just a little bit angry, but really angry, are where they realize that their clinicians haven't bothered to tell them that they have a life-limiting illness. And that had they known that 6 or 9 or 12 months ago, they may have made some very, very different life decisions. And so as we think about clinical care, we need to think about how we support clinicians, allied health practitioners, nurses, and doctors to confidently, competently, and caringly have these conversations. When we think about what are the value propositions related to palliative care, I've deliberately put function in front of comfort here. So we talk about symptom control, but as we'll see this afternoon, symptom control is not an end in itself. It is simply a means to an end. And people really want to be as independent for as long as possible. Let me challenge you this afternoon. Who here wants to ask someone to help them to the bathroom? Particularly if you know that once you've done that, you will need to do that every time. So physical independence is actually critical. And yet, how many of our services really invest in physiotherapists, in occupational therapists, in the people who can help, and I'm going to use the word deliberately, habilitate, not rehabilitate, but habilitate. How do you live with a body that is no longer predictable? Not with the expectation of improvement, but with the expectation that you will be able to function independently just a little longer because people have been helping you. And then comfort. But comfort in all of these areas: physical comfort, emotional comfort, sexual comfort, financial. You know, we did a survey independent of health service contact in South Australia of the population at large. And we asked, have you been a carer for someone in the last 5 years who was dying an expected death? Only 7% of those carers had been asked, what is the financial impact that this is having on you? 7%. And many of those people were being seen by specialist services. The existential aspects of this are critically important also. And we mustn't underestimate the challenge of that and the fact that so many people actually do not have health professionals or a caring network around them that is happy to address those issues. A beautiful study from the United States, and some of you will have heard me present this before because it is a seminal study. It was a random study of people who knew they had a limited prognosis, their carers, their health professionals, and it asked them a series of questions following no fewer than 48 focus groups to really understand what was happening at the end of life. And the number one issue for everyone, all 4 of those groups, was symptom control and personal care. So again, that concept of ensuring that there was actually independence for as long as possible. But importantly, it was not an end. It was a means to an end for everything else that's on the slide. Good symptom control allowed you to have really critical conversations with families. They allowed you to put your legacy in place. They allowed you to ensure that there was a sense of completion. Who of us wouldn't have some things that we'd want to finish off if we knew that our time was limited? But this is the list I really like. This is the list that comes from patients who know they have only months to live. 92% of patients said it was important or very important to maintain their sense of humor. It's a great coping mechanism. Who of us, after a hard week, hasn't gone home to watch a comedy on a Friday night? It's a coping mechanism. Why would we suddenly throw that away? Not being a burden, and Camilla and I were talking earlier today. You know, that fear of being a burden, not being a burden, but the fear of being a burden is a major driver for really perverse decisions by people at the end of life. And look what's not on the list. Place of death doesn't worry people as long as they've got family and access to family. Now, that's very different to where do you want to be for the majority of your care, which is in the community. But where you actually die matters far less to people than we would suggest. And I want to draw attention to that third one, being alert, even at the cost of symptom control. Being cognitively intact is critically important for, again, as long as possible. So how do we work with people to ensure that that's the case? Now, the other value proposition that palliative care brings, there's the patient, and then there are the carers. And the thing to which I want to draw attention here is that it's not only while in the role. In fact, I'd like to put to you today that a key issue in palliative care is that we are improving the health of caregivers long after they have been in the role, years after they have been in the role. And subsequently is critically important for us to understand that if we're going to provide care that improves the health of the population, we need to be measuring the outcomes for carers years, if not decades, after they have completed their role. So I first came to Canberra to work full-time in 2006, and you know, you get those phone calls, don't you? And it's a Canberra thing. Someone rings you and they go, "You don't know me, but we have to have coffee." And you think to yourself, should I do this? Yeah, of course I will. And this was a very, very senior public servant who'd recently retired. And as with so many conversations that I've enjoyed over the years, it's with, do you know the problem with palliative care? And I said, no, but I'd love to hear about it. But the point was well made. We fund palliative care, and I'm being polite here to say as a social good. The reality is we fund palliative care just enough to keep it off the front page. We do not fund it as something that is improving the health of the community. And until we change that, we have a big deficit to make up. So let's consider the future of the care economy. Somehow we just went back to the beginning. I don't know how that works, but it's pretty impressive. And now we're not going anywhere. But don't let that worry you. So, something terrible has happened to the slides here. Let's not worry about that. When we rate palliative care globally, Australia does incredibly well as a high-income country. There's no doubt about that. We provide great care while someone actually needs palliative care. And our access across the country is extremely good. So we're one of the top-ranked countries in the world in that regard. But our health systems strangely do really unusual things. People still can't die in a hospital. You have a cardiac arrest. I used to be perverse enough to write in people's notes, in the event of death, cardiorespiratory resuscitation would be clinically futile. Okay? People die, and yet our entire system is predicated on a very different patient population, and in fact, if I may say, a different era, and we'll come to that in a moment, hopefully. So why do we have palliative care and why now? Well, let's look at a few things that may help us along the way there. This is a graph, and the bottom left-hand corner is 1860. The right-hand side is 2020. So 160 years. And you can see that that graph goes from the bottom left-hand corner to the top right-hand corner, almost as a straight line. Today's fun fact, life expectancy has increased by 3 months for every year since 1860 in high-income countries. 3 months for every year. Why do we need palliative care now? Because the world has changed irrevocably. It's never going to be the same again. How have we done that? We've done that through all sorts of things over that period of time. And if we track the 20th century, it's an extraordinary century where every decade we were actually adding to people's lives with new technologies being widely available. But I want to stress, predictable water, food and sanitation is the biggest single change that we have seen since 1860. So let's look at this graph for a moment. Again, roughly the same time period. Well, actually a much shorter time period, but the point here is that we see that huge peak of cardiovascular disease in the purple. I don't know about the generation ahead of you or the generation ahead of them, but certainly my father spent his 50s going to funerals, mostly of males, mostly of people who did go to bed one night and not wake up the next morning. And that's changed. Look at that by 2016. That peak has totally disappeared. And so our health services today are playing catch up because our health services are actually geared to the middle of the 20th century, not the beginning of the 21st century. And so life has changed and it's never going to go back. We're not a death-denying society, but we need to confront a very different vitality and therefore a very different mortality. And our social services, our health services have really not come to grips with that. So most of us in this room are going to develop a chronic complex illness or several. Most of us will have those transform into a chronic progressive illness. And unlike our wishes expressed at the beginning of this talk, that we go to sleep one night and don't wake up the next morning, most of us will have warning of our death. And we will have warning of our death not by a few hours or a few days, but mostly by months, years, or even decades. And so why palliative care? Why now? People say to me, but people have been dying for eons, but they haven't been dying this way. And that is what has changed. So as we think about that, death took a holiday in the last half of the 20th century, and we're playing catch up now. So the palliative care needs that we're seeing in 2024 are nothing compared to what we're going to see in the next 20 years, because that catch up is going to have a peak. So we've got that challenge. The demographics of our communities have changed, but we also have a global shortage of carers, both professional and family and friends. Our families are smaller. Our nuclear families are much smaller. Our extended families are often geographically far more widespread than they were 50 years ago, and certainly than 100 years ago. And we already see high-income countries importing carers because we are not going to be able to produce our own, let alone what happens in middle and low-income countries, where that challenge is going to be even greater. So what does caring really look like? If we think about the care economy, we need to think about that process of providing care. From Australian population data, irrespective of health service contact, 1 in 3 of us will have had someone close to us die of an expected death in the last 5 years. 1 in 10 of us will have provided care. Just do the maths in this room alone. And 1 in 30 of us will have provided intensive day-to-day hands-on care. Now, if you do the maths about your life expectancy, or I hope your hoped for life expectancy, we're going to do this more than once in life. In fact, we will have an opportunity to do this several times in life as our life expectancy and the way we die changes. But caregiving is a health hazard. you increase the risk of death by more than 60% in the 2 years after you finish caring for someone. Now, if I increased the risk of death from a lifestyle choice, this Parliament would be making laws this afternoon. And yet for caregivers, this is a really risky challenge. There's a massive hangover effect. So what happens for people, again, irrespective of diagnosis? We know that if we ask carers of people with end-stage respiratory disease, who on average provide care for more than twice as long as any other chronic illness, that they're going to have some unmet needs. They're going to have unmet needs around information, emotional and existential support. In end-stage cardiac disease, physical care is really challenging. And yet, how many of our services work towards that? And in neurodegenerative disease, again, long time periods for which care is offered. Emotional support, spiritual support, and indeed bereavement support at a population level are areas of unmet need that have been well documented. Unfortunately, the socioeconomic gradient is alive and well. Social determinants of health are just as prominent in death as they are in life. If you are from the most socioeconomically challenged part of the community, you're less likely to live close to an inpatient service. And so we start to amplify in death the challenges that those people have already experienced in life. Now, reference was made to the Grattan report being 10 years ago, Senator. This document was commissioned by the Commonwealth 20 years ago, and it was titled "The Hardest Thing I've Ever Done." It's about being a carer. And as we think about that, we really need to understand that palliative care is actually in the community. The fact that there are professionals who do it, we are not even the tip of the iceberg in terms of the care that is offered. We are a minuscule part of what actually happens for someone who has a life-limiting illness. That is about family and friends. And don't piss your friends off, because in fact, your friends are probably going to be better carers than your family, okay? Make sure you've got a wide network of friends who really love you. I've said to people at times, actually, it's time to go to hospital now. It's time to have at least a break in hospital. Why? How many of these hats can you wear at once? And I've italicized pharmacist here quite deliberately, because we're asking people to administer more and more complex therapies at home with almost no care, no training, and no support. But if you want to be all of those things, what's down the bottom of the list? Friend, lover, and confidant. That's what goes by the by. And so there is a place for inpatient care. It's actually really important. And when we did a survey of the population, a percentage of people said, actually, that's where I want to be to die. I don't want to be there at the moment. I'm really happy being at home, but that's where I want to be to die. And that's where I want to be leading up to that time, for the very reason that I want time with my family. And when they're trying to do the laundry and cook for me and clean and look after the garden and walk the dog, I don't see them. So what about caregiving here? No start date, no known end date, very little support, and it's often really that you suddenly wake up one morning and you think, this has taken over my whole life, and you didn't even notice it coming. And finally, that people are isolated and become increasingly isolated. And I think particularly to issues such as people with end-stage respiratory disease, where that care lasts for decades, and their social network by the end of that time has been completely destroyed. It is one carer, one patient, and that's it. And that's really challenging for us as a community. So we asked carers, a survey that was done through the Palliative Care Outcomes Collaboration, And we reached out to 1,800 people, got their responses. Caregivers, 4 out of 5 said that they were anxious. Families, 9 out of 10 said that they were anxious. But what's really frightening is that 22%, 1 out of 5, had severe or overwhelming anxiety, and almost 1 out of 2 had overwhelming family anxiety as well. I mean, this is what's happening out there today. Literally tens of thousands of times over today. That's what caring is like. Not everyone wants to be a carer. I particularly pay tribute to Professor Afa Gergis, who did beautiful work on needs assessment in palliative care 20 years ago. And the tool that she developed had 2 really interesting questions, and they'll seem like the bleeding obvious to us this afternoon. One of them was, are you willing to provide the care? How often in health do we simply say, well, you've got a spouse at home, we'll discharge you this afternoon? We've not sat down with the spouse and said, are you willing to provide care? And most importantly, secondly, are you able to provide that care? We don't ask that. We just assume that someone's going to pick up the tab. Family, friends, we don't even inquire about it. And what about those who may not want to do it again? We asked people. 1 in 13 carers said there is no way that I would do this again. And another 1 in 6 said, I'm not sure that I'd do it again. So 1 in 4 people who have been a carer in the last 5 years for someone with a life-limiting illness is saying, I'm not sure I'd do this again. And yet we're going to ask of that person to do it 2, 3, or 4 times in their lifetime. So we'd better start caring for carers now if people aren't prepared to take it on as we move forward. So how can we better support people? I think there's a lot that we can do, but this is a beautiful start. Nicholas Christakis was at Harvard at the time, took a massive data set from the United States in Medicare-funded people, 1.2 million people, and he followed them prospectively. Now, as you would know, palliative care in the United States is about, the US ambassador's not around, is about 25 years behind us. So the resource that they got was incredibly small. But even if you got that resource, your chance as a surviving spouse at 18 months was greater. This is about life and death. This is not about a feel-good for the community and we'll put a bit of money into it. This is about life and death. So if you were a caring spouse and you had a palliative care service help you, even in that last few days, your chance of being alive at 18 months was greater. What does that tell us about the way we should invest? So better spousal survival at 18 months. So what can we do to actually move things forward? We look at this graph. The solid line is palliative care. The dotted line are people who didn't have access to palliative care. And on the right-hand side, we've got the people who provided day-to-day hands-on care. And we said, how are your needs met? And we can see that there's a huge gap here. If you got a palliative care service as a carer, reflecting on it, you said, I have fewer needs. That's a great message. That's a much better message. But what we see here is those graphs come together for the people who are the intermittent caregivers. They're actually generally the sandwich population. They've got mum and dad that they've got to look after, they've got kids, they're trying to work, and they see people, they see families at weekends, in the evenings and in the mornings. But they don't see any of the clinicians to have those conversations about information needs and a whole lot of other things. This was also from the same data set, following people 5 years out from the death of someone for whom they've cared. And we said, have you been able to move on? And we were using that as a surrogate for complex grief. Solid line again, palliative care. Dotted line, those who didn't get palliative care. And so we see this gap immediately between those who did and did not get palliative care instantaneously. And in fact, it takes 2.5 years to reach that same level of an ability to move on. It's not forgetting what's happened. It's not brushing it under the carpet. It's simply saying that I'm actually able to regain some of what I've had in the past. But I want to draw your attention to the right-hand side of the graph. This is 5 years out. 1 in 7 people have not been able to move on. Dear colleagues, ladies and gentlemen, I don't know a single service around the globe that is dealing with that population. 1 in 7 carers. And when you talk to these people clinically, it sounds like it was just yesterday. It sounds like it was last week that this person died, and they died in 2019. So how can we better support? Come with me to the bedside. We're almost there. I had a colleague who was dying, early 40s. So he was a bit older than I was at the time. Asset incredibly rich, cash flow zip. Wife, 3 kids, and he'd just been diagnosed with a very aggressive lung cancer. The family literally fell apart. The next generation were not there. And one of his colleagues from university flew in from Melbourne that weekend, and it was in the days of the teledecks. Still remember those beside the phone? Some of us are old enough. I'm glad to see some nods there. That makes me feel better. Thank you. And she started in the A's and she went to the Z's, and she rang every number in there and she said, what are you going to do? We can take cash. We can take a lamb casserole on a Monday night. We just want to make sure we don't get 3 lamb casseroles on Monday night, and the kids can get to sport on a Thursday afternoon. She put together in 1 2-hour session everything they needed. Suddenly money was taken care of. The kids could go to their music lessons and all of their sport. There was going to be food on the table every night. And the family were blown away. Where did that all come from? We're really very poor at asking for help for ourselves. So we took that and we said, what are we going to do with it? And so we created a community network facilitator. And that person only deals with the caregiver, not with the person with the life-limiting illness. And they would sit down and say, okay, what do you need? Who's in your network? Can you ring them? If you can't ring them, don't worry. I'm able to ring anyone. And we had a very gutsy, in-your-face network facilitator. She was fantastic. She would take no hostages. And so she'd ring up people and go, your mate John is dying. What are you doing about it? And they'd go, oh, I don't know. I wanted to offer to do something, but I wasn't sure to. Okay, this is what we need. And suddenly the network was there. And if they didn't have a network of their own, she would help them with community services that could provide that sort of support. That was a 2-year program. As that 2-year program came to an end, so did the funding. Did it make a difference? Well, I actually think in the red you can see it made an enormous difference. But you try getting funding for that when palliative care is funded as a social good. We've got in the audience today the team that are putting together this fantastic app, which is doing that in the 21st century and saying to people, reach out to your network. Ensure that you are connecting with the people around you. And I'm sure that you'll love to answer some questions after this. But it's a great idea. Let's tap into the network in a safe, sustainable, respectful way so that we can look after people in this. And that app is already being used right across the country. Absolutely critical that we think about how we support carers. 25 years ago, the Cancer Council New South Wales used to offer a live-in support person for up to 6 weeks if a parent had to leave home in order to get treatment. It was a fantastic resource, and they ceased it in about 1995. Thought, well, let's try it. So we did in palliative care. We offered that resource free of charge from 9 a.m. Monday to 4 p.m. Friday. Live-in support person. Could do anything. We even found an industrial award that would let us do that, which was pretty extraordinary. And it was amazing. People didn't want overnight care necessarily, but it provided them with a lot of support and a lot of confidence. And you can see the length of time that these were relatively short attachments. We probably saved about 1.5 years of bed days, one way or another. Otherwise, those people would have been in hospital. Why Monday 9 a.m. to Friday 4 p.m.? Because families can often find the weekends to provide care and support. But during the week, if you've already used your sick leave while someone has been going through treatment, you've got a big challenge. And so again, to your pilot, good outcomes, real savings for the health system, impossible to get long-term funding. And we've got Mira in the audience who put together the PEACH program. Palliative extended and care at home. Really critical. A resource for those last few days of life where some additional quickly mobilized resources can make a really big difference. And the evaluation of PEACH over the last decade has shown consistent benefit. But again, have we seen that rolled out nationally, rolled out at a state or local level beyond those who have been motivated to do so in the first place? 3 in 4 of those people died at home. That's pretty extraordinary. And the predictors of not dying at home certainly came back in a large part to poorly controlled symptoms. So what does it look like? Hot off the press. This was published last week. An estimate of the primary carer cost, okay? Just the primary carer cost, not the whole network, but the primary carer cost in the UK from national surveys, again, independent of health service connectivity. £28 billion sterling. That's how much people are giving to the economy on a daily basis. And remember, that is a massive underestimate, because that's only the primary carer responding. That's not the other 3 people who come in over the weekend, the person who takes someone out on a Tuesday morning. It's just the primary carer. £28 billion per year is a very conservative estimate. So, as was pointed out in the introductions by both the Minister and our co-conveners, we need some honest conversations about death and dying. Well, in fact, we need the honest conversations about dying and death. The death bit is the easy bit. The dying bit, far more difficult. And if we're going to have those conversations, we need to have them because for caregivers, we've got a real challenge. I leave you with these thoughts from the very eloquent Oliver Sacks. He had metastatic melanoma. It was before the current immunotherapies were available, just before. He would probably still be alive today if he were diagnosed the same way, and it's only a decade. But as he says, I cannot pretend I'm without fear, but my predominant feeling is one of gratitude. I have loved and been loved. I have been given much, and I have given something in return. I want to challenge us this afternoon that our demography has changed forever. And when we talk about giving something in return, I'd like to suggest that that is caring for carers. We don't care for them, we take them for granted, and our social and health systems will fall apart in the next 2 decades unless we make seismic changes to how we recognize, support, celebrate, and follow up carers long after they have done the most sterling job. Have a great afternoon.
So now is our time for Q&A. Do we have a roving mic for people in the audience as well? But I'm going to invite David back up onto the stage where we're going to have a question and answer session. For those of you who don't know me, I'm Camilla Rowland, CEO of Palliative Care Australia. And I've just been watching David's presentation and thinking, Josh Fear, our National Policy Director, there's our election campaign information. Thank you very much, David. That's right. So you talked about the care economy, but a couple of points that you've mentioned that I think are really important as well is the fact that palliative care in Australia at the moment is a postcode lottery. And that, in fact, what we also know is that other health sectors don't necessarily refer at the right time for people to start having those discussions that they have a life-limiting illness. So that interconnection between palliative care and other health sectors is still being formed. So having said that, and with your presentation, what do you think federal and state governments can do right now and into the future?
Well, at a federal government level, let's start with the simple things. I mentioned finances early in the conversation, Camilla, and as we think about the finances, we've got a carer's payment and a carer's allowance. They're actually really difficult to get. It's the only document in the federal sphere where you have to prognosticate, and that's really unpleasant for a lot of people. And, you know, the allowance covers a very small amount of the real costs, and even the carer's payment is a very small token on behalf of people who are facing this. So I think firstly we need to look at simple financial support. I think more broadly there needs to be greater recognition of carers and all that they're offering. And, you know, everyone goes, well, you know, how are we going to identify these people? We can do that. All of those things can be sorted through. But the bottom line is, unless we start looking after carers, we're going to run out of them. If you decide you're not going to do this again and you're asked for the second or third time, who provides that care? That person ends up in the acute hospital system. It's not a great place for them necessarily. The acute hospital system is really, really good for acute issues. But beyond that, we need to think very carefully. So at a state and territory level, this isn't all with the Commonwealth. I think we need to look at the carer packages and the things that state government and territory governments can do, particularly through community services. And indeed, local government, I think we've not tapped into nearly often enough to say, as we identify carers within your boundaries, what can you do to help?
Yeah, so a good follow-up question to that is about the social and health systems. How do we move to identify current and previous carers to make sure that we put in place supports for them into the future?
It probably comes under the axiom, if it were easy, it would have been done. I think the long-term follow-up of carers and their health is critically important, but actually very difficult to do. So people often are not identified as a carer in any of the medical records, either from primary care, the acute care system, or even palliative care, where you know, colleagues have done really elegant work to show that we simply list the next of kin and assume that that's the carer. So we've got a problem in identification in the first place, and then how do you follow these people up? Do you say to their general practitioner, look, if this person comes back and things don't quite add up in 3 or 4 years' time, think about complex grief. Do we say to the person, you know, you've got to watch yourself, that it may be that this catches up with you sometime down the track. And the honest truth is we've got to do all of those things, because otherwise people are going to systematically fall through the net. There is no simple solution to that. But again, community conversations, working with primary care, asking palliative care services. I really take my hat off to a colleague, Paul Dunn, whom some of you will remember from Tasmania. His favourite question was, who's going to be most affected by your death? And really interesting answers. You know, it's my 8-year-old granddaughter who I pick up from school every Tuesday and Thursday. She's the one who's going to feel this. You know, my kids, they're kind of expecting it, and frankly, they don't love me all that much. But my granddaughter, And so we've got to be far more sophisticated in this.
Thanks. I might throw to the audience now to see who's got questions from the audience. Have we got any? Because I can keep asking questions. Andrea.
Thanks, David. That was a brilliant lecture. I really enjoyed that. The thing that I had occurred to me when you were speaking was people talking about not moving on for 5, 10 years after someone has died. I'm interested to hear on your interpretation about what that's about and what needs to change in order to help people to prepare for and accept and to think of their life after a loved one has died and how they might imagine that. But what's holding people back from moving, and what do you put that down to in your experience?
Does this still work? You're perfect. Thank you. Look, as I said, Andrea, you know, in many ways, this is a surrogate potentially for complex grief. And the work that was done to get complex grief for the first time into the Diagnostic and Statistical Manual, version 5, the Bible, if you will, of those diagnoses, was really based around a number of questions from the team in Northeast the United States. But one of them was, are you able to move on? So it's not to say that it is a perfect diagnostic tool, but I think it's a beautiful screening question that helps us then think about, should we explore more deeply what's happening to this person? And that almost contemporaneous notion that this has just happened and my life stopped, I think is a very good way of characterizing one aspect of complex grief. It's not the whole picture by any means, but I think it captures one aspect really well. My life stopped at that time, and it hasn't been the same since, and I'm worried that it will never be the same again. And clearly for all of us, our lives are never the same when someone close to us that we've loved dies, but most of us assimilate that in a way that is that allows us to still live.
We did have another question. Peter Allcroft at the back.
This is the special Get Ian Fit program.
Thanks, David. That was really fantastic. Some things I can take back home and share. Those patients and families that are involved with palliative care get some input. We help to move on. We're seeing the tip of the iceberg in specialist palliative care. What does the community need for the thousands of people that don't get access to palliative care specialty teams?
Wow. Well, how big's the bottle of red that we've got to drink through as we talk through that answer? It's huge. And I think, you know, the premise is not everyone with a life-limiting illness necessarily needs to see a palliative care service. So I think that's an important premise. There are a group of people whose needs are being met really well. There are a group of people who need palliative care, and then there are the people who've fallen between the slats. And, you know, we've got needs assessment tools that have been developed in Australia that can be used by any health practitioner as an aid memoir that lasts 60 seconds to do. And you can say, well, this person actually has some unmet needs. I have a choice of, I will manage them, I will refer to my team, or I'll refer on. So we've got tools that can help us at a systems level deal with this. Again, I think it's shifting the thinking that this is just a nice to have to thinking, I am actually going to improve the health of the population I serve. And we've all got a responsibility to get that message out there, because it's simply in most people's minds a nice to have, and that's not sufficient.
Yeah, it's interesting, isn't it? The World Health Organization says that palliative care is a human right. And so we should be looking at a human rights perspective here in Australia as well. We have another question here from Tricia.
It's very well acknowledged that we've got an aging population, and so often we see that there are elderly couples living at home, caring for each other, and then the wheels fall off You talked about function, and that's usually where the crisis comes. One of the couple end up in hospital, no residential aged care. The other can't cope. They're the carer at home. Then it all falls apart. And equally, we don't seem to have enough residential aged care beds, nor do we have enough carers. Do you want to comment on that?
It's been said many times in this building that the measure of a compassionate society is how it cares for its most vulnerable. And we are failing our most vulnerable. There's nothing more to say. You know, people want to age in place. What do we really mean when we say age in place? We are not doing nearly enough to put that in place early. Data I didn't show you, but was in the slide deck on which I was working till last night, was really the concept of early involvement of a number of disciplines built around the person, their carers, their primary care, and a specialist service. And not only have we shown in a randomized trial in Australia, the largest randomized trial in the world that actually consented both the general practitioner and the patient for a health service study of this type, we showed a reduction in the number of admissions to hospital, but we also showed that early case conferencing actually fundamentally changed that person's trajectory of functional decline. Now, is that biologically plausible? It is, because you know, you had an occupational therapist come to the house several months earlier so that people didn't decondition before the occupational therapist tried to rescue things. You know, the GP was saying, I'll do a house call every fortnight. It's not in my schedule. It's not what I normally do, but I can see that will make a difference. And we saw a massive shift in general practice engagement through that process. So there are mechanisms. We do have evidence, and we really just need to move ahead with that.
In other words, we need to have that funded.
Yep. Thank you. Sorry, I wasn't succinct enough. We need to have that funded.
That's right. We have time for one more question from Linda Swan.
Thank you for the really engaging discussion. You made a very compelling case how our existing funding and our traditional funding models aren't going to meet the needs of the population that we see coming, and the tsunami of care that's needed for people at the end of life. Have you thought much about non-traditional models for funding? Is there some different way we can think about this problem? Because it feels like there's a lot of people rattling at the cage of the traditional funding models. So what else can we do that's different?
It's a great question, Linda, and we as a community need to think about what that looks like. And I really love Andrea's work. It says, let's spread this across a network. Suddenly, A, you've got support for the carer or carers, but B, you've spread that load. And it's not going to happen just with government funding. I'm not saying we shouldn't get more funding, Camilla. But it's not going to happen just through knocking on the doors of government, because government can't do this. And our networks in the community are pivotal to what we need. We need to look to philanthropy. There are lots of community organizations who want to do this, but again, how we choreograph all of those organizations for the person who at the moment is in crisis, says, I need support in my caregiving role. We don't choreograph that well. So even just better choreography of that would make an enormous difference. But I'm not being overly optimistic. It's a big ask, and we've got to move quickly.
Thank you, David, and thank you to everybody. Please put your hands together to thank David Currow for that fantastic presentation.
Thanks,
Ian.
Thank you, David. Thank you, Camilla. I think we've all had a mind explosion this afternoon. Thank you, David, for your powerful presentation. You'll be pleased to know there's a video recording that you can look back on on the Facebook page of Palliative Care Australia and our YouTube channel as well, and we'll be sharing as much as we can from David's presentation this afternoon with you, so you can take this forward into your own worlds. The final word this afternoon from the Chair of Palliative Care Australia. Mira Agar is Professor of Palliative Medicine at the University of Technology in Sydney and a practising palliative medicine physician in southwest Sydney, with a particular interest in the care needs of people living with advanced brain illnesses. Please welcome Mira.
Thank you, Ian. And I think I've been reflecting as I've heard the speakers today with our tagline, Matters of Life and Death. And I think really Paul started us in the day-to-day. I think we really need to have a deep respect that our First Nations people understood the care economy, the integration, the respect, and the connection that societies and communities can provide. And if we start our understanding and learning from that perspective, I think some of the challenges that we've been talking about today, we can navigate together. One of the things I think we need to take away from today is that matters of life and death affect the people who are having an expected death, their carers, our health services, but also our broader society and economy. And so it is a matter of living, health, productivity, and we need to tackle it from all of those lenses. The data tells us we know the problem, we have quantified it, but we also have a deep understanding of the lived experience. And many of the solutions and their impacts are well known. And so I think today, Palliative Care Australia and the palliative care sector and all of those in health and the broader community are calling everyone to consider your role in where you can influence those matters of life and death. And so we look forward to continuing those conversations across the sector and seeing some of those impactful statistics that we know in demonstrations and pilots really are scaled across the whole nation to impact all Australians. So thank you.
Thank you, Mira. That brings our time together today to a close. You're welcome to stay, sew up some hearts with our heartists from 1,000 Hearts up the back. Food and drink still available, so please stay, enjoy the hospitality this afternoon. Thank you so much for being here, and we'll see you next year for the National Palliative Care Week lecture. Thank you.